On behalf of the American Academy of Neurology and in collaboration with Neurology Today, it gives me great pleasure to introduce two of my colleagues from Italy. Leonardo Pantoni, he's professor of neurology at the Luigi Sacco Department of Biomedical and Clinical Sciences at the University of Milan, and Giuseppe Lauria, professor of neurology at the University of Milan and director of the Department of Clinical Neurosciences at the Carlo Besta Neurological Institute of Milan. My friends, my colleagues, I've been practicing my terrible Italian accent for at least a couple of days now. I had a friend texting me how to pronounce your names. So I hope, how did I do? Did I do okay?
Very well. Thank you very much.
It was very hard. I was listening to practice things online. This wasn't easy. Thank you guys so much for joining me. In the Lombardy region of Italy, it's just been I mean, throughout the world, it's been challenging, but in Lombardy and Milano and in New York City, where I'm based, we're really, Spain, of course, we've really been hit very hard. And now we're just starting to kind of come out the other end. You both did a tremendously well-received webinar. And just want to let our AAN members know that if you missed the webinar, you can watch it online. Thousands of people have watched so far. And it was just it was detailed. You had slides. You really went into details. But I wanted to kind of go into a little bit of a different direction today and talk about, well, a couple of things. First, what's new since the webinar that you did last week? Because literally, I feel like this field is changing minute to minute and day to day. But also wanted to talk to you more about how you're both getting back to our new normal, as we're calling it. You know, how do you care for patients with neurological diseases who may or may not have COVID? And maybe you guys are a few weeks ahead of us in terms of reopening and managing. So I'd love to hear about best practices. But Leonardo, from Luigi Sacco Department of Biomedical and Clinical Sciences, can you tell us a little bit about maybe something new that's happening? Is there something new? You guys are working on several publications. How are things going and what's new?
Yes. Well, thank you. There is, in fact, something new on the horizon. It's coming basically next week, because now that the pandemic is a little bit decreasing, as you know, in our region, things are going better, even if our region is still the worst, Italy, and it's going to be the last one to recover from the pandemic. Still, there is big news in the fact that hospitals now are reopening to non-COVID-19 patients, or at least, let's say, to non-COVID-19 diseases, because there have been always non-COVID-19 patients around, but the focus was just basically on them. So that means, in practical terms, that, for example, and concerning particularly our neurology unit, that next week we are going to reopen inpatient clinics that have been closed for 2 months now. And the second thing is that beginning next week, or in a week or so, we are going to restart our outpatient services for neurological patients, I'm referring, because of course the entire hospital has been devoted to the pandemic, the COVID-19 pandemic issue for the last 2 months. So that's the big news. And maybe Giuseppe wants to say something else. Then I can tell you a little bit how we can try now to figure out how to restart and reopen the services.
Yeah, it's something we're certainly struggling with. Giuseppe, what's happening? I know your wife, I believe, heads up a neurology at a different hospital, the Metropolitan Hospital. Tell us about your perspective.
Well, yes. What Leonardo said is what has happened in the early weeks when you know, from the first patient, which was notified mid-February 18th. If I remember well, and then, you know, week by week, it was an increase, you know, to 100 and then thousands and 10,000 and so on. So there was a complete reshape of the activities in the region. And yes, my wife is a neurologist, and she became a neuropneumologist, as we said, because, you know, many of the neurological departments admitted as inpatients COVID-19 patients to be treated for their lung disorders. And so there was also this kind of reshape of the activity as neurologists, not only as neurologists, to be honest, because many friends, surgeons as well, for example, orthopedics or whatever, gave assistance to these patients, and some of our doctors went to our hospitals, to other hospitals. Ours, this Carlo Besta, is a research hospital, and we have been part of a regional hub for neurosurgery, which worked very well, to be honest, because there was this activity to bring here patients with neuro-oncology diseases. And for the neurological part, we have reshaped our department, keeping the hospital COVID-free. At least this is what we try to do. And we managed this more or less well, to admit neurological patients, no COVID, who needed to be admitted in a hospital, but who couldn't find a bed in any other hospital in the region. This is important because, you know, in our hospital has a national based patients. So we admit we have nearly 55% of patients from out of our region, and mainly from central and southern Italy. And of course now all the traveling is closed, all the regions are closed, so we did that. Now we are moving to the second phase, managing all the patients here as potentially positive. So we have a triage here for all the patients admitted, and we are reopening also the outpatient clinics with keeping all the doctors and the nurses in the best safe condition while seeing the patients.
When it comes to reopening the outpatient clinics, you know, we are in New York City. We're just about to start to do that as well. We've always seen kind of urgent cases and specific procedures that we had to do that were urgent. We've continued those, you know, in a scaled down way. But as you are preparing to open up the outpatient neurology clinics, have your hospitals or administrations come up with specific guidelines? What are some maybe best practices, or maybe is it even too early to tell?
Well, there are more or less specific guidelines released by the regional health system that each institute and each hospital should follow, of course. Basically, the way we are seeing things, and we are going to reopen the outpatient clinics, is to do that very slowly. So that means that basically the amount of patients that we are trying now to select and to call for the visits is much lower than in the past, and the usual amount that we have per week. And that is because, of course, we need to have more distance from patients. We do not have to have crowded places outside the outpatient clinics. Patients have to stay in the hospital the minimum amount of time required for the visit, and then to quickly getting in and quickly getting out of the hospital in order not to remain too long inside. Of course, this is going to be completely new for us, so we will need to test how it goes, if this is too slow, too fast, if it works. One thing that I can say by now, and I think it's important also to report to colleagues who are in other countries where the pandemic is going at different times in respect of Italy, is that we are calling back patients for the outpatient services. Many of the patients are a little bit reluctant to come to the hospital. So even though now there is the possibility to come to the hospital for the visits, which has not been the case for the last 2 months, still they are not very much prone. At least 50% of them, they don't like too much the idea of coming to the hospital these days.
Yeah.
So it will probably take a few weeks, if not months, to have the response by patients the same as it used to be in the past. And this goes, of course, in parallel with the reopening of the social things that we are facing now in Italy. Now, beginning on Monday, we think, we're not sure yet, that there will be another step down in the reopening, for example, of restaurants and bars around, with a lot of restrictions, of course. But it will take some time for people in general, and for patients in particular, to go back to something that is not normal, but more close to normal in respect of what has been in the last 2 months.
Yeah, in New York City, we're confronting the same thing. A couple of weeks ago, we sent out emails, personalized emails to our patients just to say, hey, we're doing video visits. We hope to be open in a few weeks, but stay in touch. And now we're kind of reaching out to say, okay, we're planning to open again, and we're having a very similar issue. I would say it's more like even 60% of people, and we're a couple of weeks behind you, but I would say at least 60% of people just aren't even ready. Okay, we'll do this. Let's do this summer, or maybe I prefer a video visit, or let's. Is there any other way we can do it? So I agree with you, and we look forward to scaling up, but we need patience to scale up too, and that may still be a little while.
Well, if I may say, this is very important. I don't know to what extent this will change our practice in the next few months or maybe years. I don't know. For sure, it also makes a kind of clustering regarding the type of patients who are more prone to go into a video visit rather than coming here. For example, so we have done a lot about that, and for example, headache patients, but for other type of patients, or patients suffering from other diseases, the barrier is really very, very tough. Just to make an example is, still patients waiting for receiving a diagnosis of ALS, which is a very tough moment. We haven't done that. I mean, we have postponed them. We try to make some corridor to have to send them to make the diagnostic exams. But then at the moment when you have, so we are restarting this. What has happened to me this week actually is that in that phase, for example, which is also very emotional, what was felt quite embarrassing and needed to be somehow fixed is that we were talking about a diagnosis very tough with the mask.
Yeah.
And at a certain point, it was necessary for me to take it off.
Yeah.
And for the patient, at least to see each other in our own eyes, and not only through the eyes, now, because through the facial recognition is very important when you are telling something so relevant, which is a diagnosis like a neurodegenerative disease, but in many other cases. So we will see what is happening in the next future, and how we will have to manage the telemedicine in the future, because it is a brilliant idea, but I don't know as neurologists to what extent it will be possible in practice. For example, we have started only for control visits, not for the first visits. Okay. And it could be a matter of debate, but this has a sense, because you need to visit someone. So we will see.
Yeah, I agree. The concept of trying to convey an emotional diagnosis that has such long-lasting impacts on the patient, the whole family, and you can't even communicate in the normal way. You can't show compassion with facial expressions. I think that's That's tough. That's tough. And then what's worse, communicating a diagnosis like that, not in person, on a video. Well, you can see the facial expressions, but I think that's probably worse. So this is these are challenging times, especially from that aspect.
No, I don't know actually whether we are already ready for this, because it's a completely different way of making medicine compared to what we have been taught, like when students and practice in the first year. So it's a different way for the patients and for ourselves as well.
Yeah. One of my mentors in Boston was Lewis Kaplan, and I remember very vividly. Dr. Kaplan's an amazing guy, and I remember vividly when he talks to a patient, especially about something serious, he sits down next to the patient and he puts his hand on their wrist, and he makes or on the shoulder, and that physical personal touch is kind of what makes neurologists. It's interactivity, it's personal, it's compassion, and we can't do that anymore. I can't imagine what you guys. Right. That's all. That's all the touching we can do. Unbelievable. And aside from medicine, how is all of Italy managing without giving kisses on the cheek? That's a whole nother problem. Huh.
We are becoming much more North European.
So you guys have been publishing, you guys have been studying about the complications. I think you have a new paper coming out pretty soon. Maybe you can tell us a little bit about some of the publications you've been working on. One of the things I learned in the webinar that I hadn't really seen too much here in the United States was, you talked about the more common neurological complications, the less common that have been reported, but you covered syncope. That was a very interesting component. I had really no idea it was that high. That now I'm understanding more. We see more GI disturbance. I think you have a paper that's talking about that. Neurological symptoms in children is probably a whole new area. What are some things that you're learning? Some papers that we should look forward to coming out.
Giuseppe.
Well, while we're talking with Leonardo and preparing our webinar, actually, one thing actually came up. So the fact that in these really incredible times in our field, in neurology, it seems that, disorders or associations between disorders and COVID could become, quite clear, but actually, or specific, but actually doesn't seem the case in most of the conditions, and actually also in most of the papers. That story of the syncope maybe is one possibly specific, and it was part of a study. I've got the privilege to be part in a hospital nearby Milan, in Crema, where they were pretty well organized from the very beginning of the outbreak there, and so it was possible to see nearly 500 patients and longitudinally. So all the patients underwent the same exams, and what we observe is that about 10% of these patients reported syncope, one or even more syncope, in the 2-3 days before. That was, in patient without any other condition predisposing to that episode. And so we reasoned about that, and actually we found, and we look at this group of 35 patients who all had a clear hypoxemia at the arterial blood gas analysis, along with an interstitial pneumonia at the chest CT. What was interesting is that those patients who didn't have any electrocardiographic abnormality in terms of QT or whatever, they did not show any increase in terms of heart rate, which is expected when you are in hypoxia. And The idea is this: it is possible that since the heart rate is regulated by the nucleus of the solitary tract in the brainstem, where there is this baroreflex center, which responds clearly to hypoxemia. Well, in that nucleus, the AC2 receptor, which is the binding site, as everybody knows now, of the spiky protein on the envelope of the COVID-19. And we know, we learn now that this binding causes the internalization of the AC2. It might be possible that in these patients, there was an internalization of this AC2, causing the impairment and an increased sensitivity of the baroreflex response. And this is quite interesting because it mimics what has been demonstrated in animal models after the delivery of AC2 antagonist, which essentially, like an internalization, blocks this protein, which causes exactly the same event, so a response in bradycardia and an increase in the vagal tone. So it might be possible that this syncope is a quite specific event occurring in at least a subset of patients. It is quite strange that there wasn't any paper reporting this. We have prepared a letter. Maybe we will be able to publish this somewhere. I don't know. But talking with colleagues in many hospitals, many of them reported that syncope has been experienced by patients in the days before. So that could be one.
That's great.
Yeah. And if I may make a general comment, and Giuseppe knows very well that, because we have been discussing this for long days and for many weeks now. What we I think what we miss now is the clear evidence that something is specific to COVID-19 infection. I think that the case and the problem that Giuseppe was referring to is probably one of the issues which I think it's probably more specific for the disease. Other conditions and situations that have been described, even reported, sometimes even reported in a very high-level journals. I'm not that sure that they're really specific for this virus and for this infection, because one thing that we are facing now, and I think we should all be very much aware of this, and I hope that all the colleagues in the American Academy of Neurology are very aware of this, is that there is a trend for including everything under the umbrella of COVID-19. Yeah. And everything is referred to that infection. But chances are that some of this is not very much specific to this infectious disease. It's something that we see in other infectious diseases. And of course, we are seeing more of these things because we are just seeing more of these cases all together, all at the same time in a very dramatic way. The other thing is that we are not seeing other things. And the best example of this, of course, concerning neurology, is the unbelievable decrease in the number of strokes we have seen over the last 2 months in our region, in our country, actually, even in regions of the country where the pandemic was not that great. You know, in the south of Italy, the amount of cases is very little, actually. But we have seen this trend of really disappearing of stroke, which it's kind of the same for myocardial infarction, but specifically for stroke is very hard to explain. And the only two hypotheses that we were able to bring up is that either the two severe strokes were not brought to the hospital, actually. For example, very old people, they remain home in a very bad situation. The other thing is that probably the not very severe strokes, they stayed home the same. So people with mild symptoms, they were probably not treated, they stayed home for the same fear of going to the hospital we were referring before, talking about outpatients. It's the same thing. So these are the two only explanations. The third one is probably that some of the strokes have not been recognized in COVID-19 patients for many reasons. One could be that they were in the intensive care units, and in the intensive care units, some of these neurological problems, specifically strokes, are not easily to be recognized. The other thing is that probably there was so much focus on the lungs, on pneumonia, on respiratory distress, that other symptoms may have been really gone, not seen by the doctors around. So something that probably we will understand in an amount of time from now, not now. Probably we will see also the reflection of this in the next few months, maybe years, because these things take years to be seen from the epidemiological point of view in the correct perspective. So that's an important point that I would like to make for all our new colleagues in neurology.
Yeah, I totally agree. Not being able to do a comprehensive neurological exam because we have to limit our time with the patients. We have to keep a distance with the patient. It's harder to communicate with the patient for not just a mask reason, but potentially due to intubation. We can't communicate well with those patients at all. So those are key points. And I think, in the United States, and actually I think there's a consortium now around the world, the Neurocritical Care Society is put together a registry. There's over 50 sites globally that have jumped in. And then actually someone just emailed me the other day that now for pediatric neurology, they're also adding neurological complications, really a registry, IRB approved, prospective, a rigorous approach to truly teasing out what's real and what's not. Because the last thing we need is to, all these little case report, even in some very, very good journals, just like you said. But is that really causative? First of all, are there neurological complications? Well, sure. I think there's several, probably maybe more than we realize, but we're not sure yet. And then if there are, well, how common are they? Can we, for example, anosmia was a very important sign that, a lot of people said, well, maybe it's not specific, it's sensitive. Well, actually, that's a pretty robust, the data has been really showing that when you have isolated anosmia, that could be a presenting sign of COVID. And of course, there could be, other things, but, even GI disturbance, for example, I think you guys have one of you has a paper coming out potentially about GI disturbance, that took a while to come out as a presenting sign. So we're learning a lot, but I agree. We have to take a rigorous approach to try to, document things and publish and study with rigor.
Yes, it's very important actually because for example, you have mentioned anosmia, and also GI, but actually there is a biological reason for this, which goes back to the expression of the receptors on the endothelial cells on the olfactory bulbs. That's the point. So if you look at the papers published, actually in none there was the evidence, or if I'm not wrong, of RNA into the spinal fluid, cerebrospinal fluid. So where is the relationship between the two in terms of encephalomyelitis in the cases reported, or in the immunomediated neuropathies? Or let me say, in our journal, I am the editor-in-chief of Journal of the Peripheral Nervous System. Let me say that we have in a paper from Germany reporting a case of GBS, which was quite interesting because that patient did not have any flu-like or infectious disease, which is very, very common before GBS, but only few symptoms, including anosmia, reporting to COVID, and she was positive. So it might be the case that in some patients there was a kind of molecular mimicry also with with COVID-19. But for the rest of the other patients, including some myasthenia patient, it could be just a coincidence. The fact that there has been the diagnosis of that disease during or in patients with at the same time the infection. So we don't know whether it will affect the incidence or the severity of chronic diseases. In my experience, patients with CIDP, so with the chronic neuropathy, inflammatory neuropathy, we haven't seen, of course, it's a limited cohort, it's something like 20, 25 patients, but we haven't seen an increase in terms of time to relapse or more severity of the relapse. So we will see. For the GI, yes, in the same cohort, we have found that quite interestingly, 10% of these patients reported GI disturbances. This has been reported from other cohorts, more or less with the same number of patients. That could be probably interesting because nearly 1.5 did not have any respiratory involvement first, so it means that there could be the relevance of the orophageal
transmission
infection could be important. At the same time, actually, there is a biological counterpart regarding this. But we will see what among the chronic neurological disorders and to what extent they will be affected by the disease. In generally speaking, I think that looking at the epidemiology of this disease, it doesn't seem that there was, an increase in terms of acute neurological disorders in patients with COVID-19. What do you think? I don't know whether you have the same experience there.
It's, yes, it's the same experience. We haven't seen anything really specific to say, well, this is very typical for the diseases, except maybe anosmia, and if you consider that a neurological problem, the disturbances, of course. All the other things are not very much specific for that. And another point, maybe the last point I would like to make, again, for our colleagues on the other side of the ocean, we're probably going to see the situation in the next few weeks, is that now that we are entering the phase 2, we are also seeing different COVID-19 patients. I mean that the severity of the disease of COVID-19 infection seems to be very much lower than in the first outbreak two months ago. There might be explanations for that, but of course it's not very much clear why. And this is important because we probably need to get used to see more and more patients with very mild COVID-19 infection who have instead severe neurological diseases. And the leading disease has to be the neurological disease, not the COVID-19. So we as neurologists probably have to become used to treat patients with COVID-19 disease who are not very much symptomatic, for example, for the respiratory part, but who are instead, affected by neurological diseases. All these patients have been put in the COVID-19 wards so far, but now we need to bring them to our units in order to treat in the correct way the main disease they have, which may be neurological, maybe cardiac or whatever, can be a cancer problem or whatever. But the disease seems to be changing a little bit. So we might see again in the future more COVID-19, let's say positive patients who are not really diseased in terms of lung impairment or respiratory impairment. That's an important point that we all need to change our use.
Yeah, and from a purely clinical observation, I'm not using any data to support this, but I think we're seeing similar things, and maybe it's just because patients are coming in more outpatient and they have lower grade infections, and before those we wouldn't even really see that. We would only see the severe. So I'm not exactly sure why, but we have seen a very similar thing. And I've been paying attention to some of the data on the mutation. How there was was a strain from China that seemed to go to the west coast of the United States, and maybe those infections were a little less virulent and less severe. But then the European strain that hit New York City was very severe. And is that because the virus mutated? Is it because of, genetic susceptibility? Just as an anecdote, again, not truly data driven, but one of the first families in New Jersey, an hour from New York City, I think the first family where multiple family members died were an Italian family. And of course, that could be, total coincidence, and it is, that kind of thing. But maybe not. Maybe there are some inherent genetic differences. People were saying, well, men are affected more. Maybe it's because they have more smoking or more this. But actually, no. It may be because of sex differences in men with the ACE receptor and other things. So I think as the disease unfolds, and I think hopefully it's going to continue to mutate, but hopefully, a vaccine comes out. But I think we're going to have to tease out exactly the reasons why the disease affects certain people in certain ways. And who knows, maybe certain people will have more neurological complications, and we'll be able to tease that out with data.
Yeah, I agree.
Great. Well, thank you so much. I've learned a lot. I really enjoyed talking to both of you. Leonardo, Giuseppe, how'd I do? Better?
Good.
Good. Okay. Yeah, I'm sweating. It's hard. Hard to get this accent right. Thank you so much for your time. We really appreciate it. On behalf of our 36,000 members, we say thank you. And if you are ever in New York, whenever the world opens up again, we can go to my favorite cafe. It's called St. Ambrose, which I believe is the patron saint of Milano. And a cappuccino is on me.
Okay, thank you.
Okay, cool. Nice to meet you guys. Take care.
Be safe.
Thank you very much.
Oh, thank you. Take care. Bye-bye.
Thank you very much.